Over to you, Dr. Chandra.
So wonderful evening to everyone present here, along with Dr. Suresh Kumar Murugesan, and on behalf of the core team Mental Health Webinar Series and the organizer, the Department of Psychology, the American College Madurai, and the associating partners, Madras School of Social Work Chennai, Red Pond Educational and Psychological Research Center Madurai, MS Chellamuthi Institute of Mental Health and Rehabilitation Madurai, Yellow Pond Counseling Center Madurai, and Psycho-Oncological Association Turkey. We happily welcome you all to today's 400th session. And we welcome all the participants and the resource person of today. And today we have Dr. Selvi Kumari with us, and she is currently the consultant clinical psychologist at Ahana Hospitals. So very happy to have you here, ma'am. Thank you for accepting our request and being present with us this evening. And we are very looking forward to listen to you about your case on how CBT is helping with OCD. And now I request Dr. Suresh Kumar Murugesan to talk a few words about the speaker and introduce her to the group. Thank you, sir.
Thank you, Dr. Chandra, and wonderful evening to each one of you present here. And it is our milestone session. 400, it is not an easy task. And we never thought that we reach this milestone. And this milestone session, we are going to have it from the person who is practicing in the field of clinical psychology. Dr. Selvi Kumar is known to many of the professionals in the field of psychology because of Dr. C. Ramasubramaniam, sir. She is the daughter of Dr. C. Ramasubramaniam, sir. And Selvi Kumari, madam, is, I can say one word. I think the nodal agency for mental health is on, we all know that NIMANS. And doing PhD, it is very difficult, and she has done her PhD. That one word is enough for saying her credibility and sound knowledge in the field of clinical psychology. And as per my knowledge and interaction with her students of different stages, master degree level and the PhD level, and their feedback, it shows that she's a systematic person and she gives all the inputs in thorough examples and what the things they have to do. So such a meticulous person she's here with us. She's going to talk about that CBT for OCD. I think there are many number of participants are joining. When the double the numbers I can see here, it shows that the resource person, the name pulls this number of participants. With that note, I can give a space to the resource person. We would like to hear a lot from you, ma'am. Over to you. Thank you. Thank you for coming and accepting our invitation.
Thank you very much, Suresh, sir. I think hats off to you for pulling off this entire webinar series. I think a very active engagement in the academic field in this area of mental health was largely stimulated by you and, of course, the entire supporting agencies involved behind this. So it's definitely an honor and privilege to be a part of this initiative. And I'm glad to address this academic group, who I know is the end of the day. 6:30 is when we wrap up. But the 50 of them who are here today, it just shows me how motivated you are to still learn and add knowledge to your existing pot. So it gives me an immense responsibility to keep you all active. It's not just post lunch, but it's also, end of the day. So let me see how what justice I can do to the topic that I've taken as well. Before I start with the presentation, let me also be very upfront and open with all of you as to covering CBT for CBT itself is a very, very, a very vast topic, but it's a very interesting topic, no doubt about it. That within the time limit that I have of about 1 hour's time is going to be a huge challenge. So before I even start off, I'd like to, set the expectations of the group also clear in terms of this is going to be a very, very brief outline of what one should do when a client with OCD comes and what are some of the CBT aspects that you need to keep in mind. So an in-depth, let's say, training, it probably will have to be reserved for another day. But within 1 hour's time, let me see at least if there's something that you can take away from this topic. So with that, on that note, let me share my screen. Second. Yeah. Is it visible, Suresh Pasa? Yeah, all right. Okay, so let's start off with the presentation itself. Okay. So today what I'm going to do, the topic itself is CBT for OCD, a clinical case presentation. Of course, I represent two parent organizations. One is MS Chelamuthu Trust and Research Foundation, as well as Ahana Hospitals. Both these organizations have been pioneer in the field of mental health over more than 2 decades in the southern Tamil Nadu. So happy to represent both these organizations in my presentation. So let's have an overview of what you can expect. Okay, so for those who know OCD, well, great. For those who don't know OCD, I'm going to give a quick glimpse of what OCD is, and then about common treatment approaches of which is available for OCD, and why do we have to do, or why is CBT even a treatment option? Okay, so a question to answer that. And then thereafter, we go into what are the therapeutic stages or what are the components of CBT as to what is involved in CBT, what is it all about for OCD specifically. And then as we go through the components, I'm going to parallelly walk you through a case so that there is a match between theory and a practical case that you can relate to. So what is OCD? According to the APA, which is the American Psychiatric Association, if you see OCD, it's characterized by 4 important significant features. One is the presence of obsessions, compulsions, or both. Second is the whole act has to be time-consuming. The third is it significantly interferes with the individual's daily routine, work life, family life, social life, and it causes marked distress. See, one might wonder, I mean, now let's say if I've done something, now let's say I see my hands and I find it dirty, I clean it, I probably wash it once or twice. How is that different from somebody who ends up doing repeatedly? Now, as we go through the presentation, I hope you have clarity about that, which is also covered in the following slides. So OCD, if you see, it's seen as one of the very common psychiatric illness with a lifetime prevalence of about 1 to 3%. It's actually the 4th most common psychiatric illness and in fact a leading cause of disability. Earlier, actually, people were not familiar with what OCD was or the number of people who had this problem. They didn't even know that it was a problem. So thereby, it was largely because people didn't know it was a problem, it was not reported. Now that the awareness is increasing, people have come forward to see that as a problem and take help and take treatment, which is very much available. So it causes a significant impairment in the functioning and quality of life of the person, including causing a disability in the person's life. Early diagnosis and appropriate treatment, like many other mental health problems, definitely improves outcome. It is a very common problem, but it is also a secretive illness because of the shame and embarrassment associated with it, which is quite common in a lot of other mental illnesses as well. If it is left untreated, OCD can or it has the danger of becoming a chronic illness with the waxing and waning of symptoms. When we see waxing and waning, it's more like you might have an ebb and a tide and an ebb and a low. So let's look at what exactly is obsessions. We've been talking about OCD. So what does that O stand for, obsessions? If you look at obsessions, they are repeated thoughts, urges, or mental images that causes anxiety. When I say repeated thoughts, when I repeatedly have a concern that my hand is dirty, maybe the door is not closed. What if some harm might come to people who are close to me? So it is not just one random thought, but it is a thought which keeps happening repeatedly. It can even be urges. An urge to, let's say, you're walking into a shop, an urge to pick up something. That's very different from kleptomaniac. Kleptomaniac is they have an intention of wanting to do it. But in case of obsessions, I don't want to pick up anything from the shop, but I repeatedly get an urge to lift something from it. So that can also be an obsession. Or obsession needn't necessarily be thoughts. It can also be images. Okay, now let's say a client of mine, a mother, had repetitive images of throwing her baby in front of a truck or in front of a lorry. So it was about repetitive images of the baby being thrown in front of the truck. So there was no thought there, but there was only a mental image. Or for that matter, even consider sexual obsessions. An image, a blasphemous image of, let's say, godly images, let's say, defecation on godly images. These are still real obsessions that people do experience. So, as the character of obsessions, one might say, they are unwanted, which is, I don't want to throw my baby, onto the truck. I don't want to see smearing of fecal matter on God's idol, but I'm still getting it. So it is unwanted. It is unwanted. Second thing, it is intrusive and interfering. It is interfering with my daily routine, and I'm not able to perform my daily routine. The third most important thing, it is ego dystonic. When we say it's ego dystonic, it means that I don't want it to happen. I don't want it, but it still happens. So that's what ego dystonic means. Opposite of ego dystonic is ego syntonic. Ego syntonic is, yes, I want to throw, I want this to happen. That's ego syntonic. Ego dystonic is, it's something which I don't agree. And the last important character is, we try to resist it, we try to stop it, but often it is resisted unsuccessfully. So these are, characteristics of what one can qualify as an obsession. Some of the very common examples, if you see, fear of getting contaminated. My hands are not clean. The bathroom is not clean. The toilet seat is not clean. The water is not clean. What if I drink this water and, I catch some illness? So all these are fear of germs or contamination. It can be unwanted, forbidden, or taboo thoughts involving sex. It can be two of God's pictures involving in sex. So this is something that can be a very, very forbidden thought. But the reality is that people do experience these obsessions as well. Harm, harm, as I told you, I think one of the examples which I told you was a mother having to, throw the baby onto the truck. Aggressive thoughts towards others or self. One of my client, if you see, has a very strong obsession that some harm might come on to her parents. Something harmful can happen to her parents. So she ends up not going for college and ends up sitting the whole day at home, sitting in front of them and watching that no harm comes to them. So if you see here, you might wonder, is it a referential idea, or is it a paranoid idea, or is it an obsession? It is a clear obsession for a simple fact that she understands that she doesn't want it, she doesn't believe in it, but it comes, but she's not able to overcome it. So that's how we also differentiate between an obsession and a paranoia, which often gets mixed up when we look at aggressive thoughts. The next one is having things symmetrical or in a perfect order. Let's say my pen has to be like this, or let's say the books have to be like this. If the books are not like this, then I will not get good marks. Or if I don't take the third bus to my school, then it means I'm going to fail. So these are also some of the examples of obsessions. Now let's look at the other side of it, which is compulsion. What are compulsions? These are repetitive behaviors. And let me tell you, just like how obsessions could be images, compulsions can also be purely thoughts. Your compulsion needn't necessarily be a behavior. Your compulsion can also be a mental act. Now, let's say for example, the mother who had a obsession that what if I throw the baby onto the truck? Now, the compulsion for her could be she needs to consciously imagine in her mind as if she's holding the baby and hugging the baby and cuddling it and giving that affection. So that can be a compulsion, which is purely a mental act. And why they do it? It is aimed at reducing the distress or preventing the occurrence of a dreaded event in response to an obsession. An obsession is going to create a sort of a distress. To reduce this distress, what I do is what we call as a compulsion. As you see here, these are all the examples. It can be cleaning, hand washing, cleaning compulsions, hand washing compulsions, keeping things in a particular order, repeated checking whether the lock is locked or whether the application form is filled properly, repeated checking. Compulsive counting is I need to count these many times. Only then I'm satisfied that, this thing is done properly. If I count 50 times my homework, only then it means that it's done properly. So these are some of the examples of compulsions. Well, I think this is a mental picture that all of you will have to freeze and keep in mind. Even in the middle of the night, somebody wakes up and asks you about CBT for OCD. This is the crux of the understanding that both as a therapist as well as a client, you need to orient them. Okay. Now, are you able to see my cursor move as I take this? Are you able to see my cursor move? Yeah.
Yes,
right.
ma'am.
Okay. So I'm going to show you as to how this whole thing works. One second. Yeah. I'm going to show you how this whole thing. I'm going to show you how this whole thing works. So this is a cognitive model of OCD. Is there any way I can pull back this? One second. Is there any way I can? Okay. All right. I'm very bad at technology, so sometimes, yeah. Okay. Right. So as you see here, this is Freeston and Ladouceur's 1997 cognitive model of OCD. There's nothing very difficult about this diagram. If you can actually look at this, it's a very, very simple, commonsensical thing that you can understand. Okay. I'd like you to imagine someone coming to you with OCD. Okay. So this picture right here, which is the internal or external clue, can be a sort of a trigger. Okay. So there is this trigger. When a person has a trigger, let's see, one second. Yeah. So this internal or external cue is the trigger. So when a person is faced with a trigger, now let's say, for example, I'm going to give you a very simple example so you can understand and relate to it. So a trigger can be, let's say, I've just closed my door. I've just closed my door and come back here for the presentation. But when suddenly a thought appears to me, or let's say I've just locked the door, but I'm looking at the door. When I look at the door, I see the lock. Okay, so looking at the lock can be an external cue. Or let's say I'm not even seeing the lock. I've sat back, I'm sitting here talking to you guys, but then I'm having a thought. I'm having a thought of the picture of the door and the lock. So that's an internal cue. So your cue can be internal, which is a thought, or it can be external, which is an object. So when I see that cue, what sort of a thought which I get? So as I see this cue, there is a thought that comes to my mind. Okay, it's not even an obsession, it is just a thought. So this thought comes to my mind that what if I have not locked the door? Now, of 10 people sitting in a room, when you've locked a door and come, how common or uncommon is it for people to have a thought? Is the door locked or not? Have I locked it properly or not? Is it common or uncommon? Sometimes in this webinar, that's the problem. When we are face to face in a workshop, it's a lot easier to interact. But when it is in a webinar, sometimes it so automatically comes.
Okay. Ma'am, sometimes it happens to normal people also, like whether we block the door or not. Once we come out, sometimes it happens. Rarely, rarely it happens.
Right. Actually, on the contrary, it happens, for some, it happens rarely, but very common that people just get thoughts, whether my door is locked or not, have I switched off the gas stove properly or not? Okay. So
especially with the gas stove.
Especially for homemakers, and people who are running up for work. Yes. So thanks for that response. So as you see here, It is a thought that anybody can get, but what turns it into an obsession is this one. As you see here, this is something called as a cognitive appraisal. A cognitive appraisal is nothing but how much importance I give to that particular thought. Now, this cognitive appraisal is the actual culprit in this entire, illness, because getting a thought whether the door is locked or whether the gas stove is closed is not something which is rare. It is something which is common. But what makes it a problem is the amount of importance we give to that thought. Let's say of the 10 people who gets a thought like that, there could be 7 of them who are like, okay, maybe I've locked it, or maybe I've, closed the gas, and then you just keep going on for the rest of the day. But there could be those 2 or 3 people who have a feeling, no, if I don't check the lock, or if I don't go back and check the gas stove, something terrible might happen. What if somebody comes and steals things at my house? What if there's a gas stove, blow up at home? So it is actually not the thought which is the problem, but it is how cognitive is, what is the importance that you give to the thought is what that actually is the problem. Okay, so the more importance you give, when you cognitively appraise it to be something very significant and important, what happens? Your anxiety increases. If you consider it not important, there is no anxiety at all, or your anxiety is very minimal. Because you're giving it a lot of importance, your anxiety increases. When your anxiety increases, what you feel? You feel the need, you feel the compulsion to go and check it, to go and do the response so that there is a reduction in the anxiety. So when you perform the compulsion, your anxiety reduces. So this is the basic framework for us to understand. Even before, this is basic, for you to do a CBT for OCD, you need to understand what is the theoretical basis for it. Well, this is the theoretical basis for it. Okay, so as you see here, any guesses of this entire, cycle, which do you think is going to be the target of our therapy? Any guesses, any answers? Which do you think is going to be the target of our therapy?
Cognitive appraisal.
Perfect, exactly.
Cognitive thoughts. Okay.
It's actually not the thoughts, it's not the anxiety. The culprit is your cognitive appraisal. For the simple reason that you can't avoid closing the door. So you can't avoid the queue. You have to be, you will be exposed to locks, you will be exposed to gas stoves. Okay. On the other hand, so that's also something that we can't avoid. When we look at the lock, you getting a thought whether you've locked properly also is within your control. But what is within your control is the extent of importance you give to the obsession. So that's why this is within our control. And if we handle this, if we reduce this, we reduce the anxiety, thereby prevent the compulsion, and thereby we cut off it becoming an entire vicious cycle. Okay. Right. So having understood that, let's.
To interrupt here one.
Yes, sir.
Ma'am, actually,
Sorry.
the appraisal is coming to mind because of some past experience, past incident where I have committed some mistake.
Absolutely, sir. In fact, as we go through the presentation, you will understand.
Have closed or not?
Sorry, have you?
Yes, yes.
So let me just check whether I've understood the question right. So you're asking whether this cognitive appraisal is because of early past events or past experiences, right?
Yes, ma'am. Yes, that is deep-seated in subconscious mind.
Right. Now, as we move through the presentation, you will understand as to why is that of the 10 people, 7 people are able to walk away, whereas the 3 people end up yielding to the obsessions. And the answer rightly resides in your relevant past history, early childhood experiences, early It can be even experiences in your young adulthood. So early relevant life history does shape up what sort of a cognitive appraisal you give to a particular situation. It will be covered in the subsequent presentations. Okay, right. So let's move on.
Thank you.
Yeah.
It might not be due to weak memory, madam.
Sorry, sir. Well, it can be due to weak memory 1 or 2 times. But again, probably the answer to your question resides in the next slide. A weak memory is something very, very normal. Okay. When is it beyond normal? When is it beyond just a weak memory? Okay. So these four boxes gives you the answers, sir. So the first answer is, when is it beyond normal? When you have difficulty controlling despite it being excessive. Okay, I know that I have just now locked and come. I do remember that I've just locked it, but still, I am getting this thought. I still have doubt. So I understand that I've just done it, but still I'm not able to control it. So difficulty controlling. Okay. Second thing is, at least 1 hour a day is spent on all these thoughts and behaviors put together, a minimum. Third thing is, I don't enjoy doing it. There's no pleasure. But when I do it, at that point in time, it relieves my anxiety briefly. The fourth point is, it is causing a dysfunction. When I keep on checking these things, I have a delay in going to work. I end up going to work late. It causes a problem at my workplace. But despite it causing problems in my life, I'm still not able to control it. Right. So having looked at OCD as definitely a problem that can impact a lot of people, what are the treatment options for OCD? So if you look at it, largely you have biological treatments and you have psychotherapeutic approaches. In biological treatments, you have pharmacotherapy, you have the transcranial magnetic stimulation, you have psychosurgery as different approaches. Of course, largely the first line of treatment is the SRIs, which is the serotonin reuptake inhibitors, as the first line of treatment. Psychotherapy, if you look at it, there are a large number of therapeutic approaches. Besides CBT, if you see, there's not cognitive behavior therapy, but just behavior therapy. Then you have the mindfulness-based CBT, acceptance and commitment therapy, stress management, relaxation training, thought stopping. So these are all different methods of doing it. But if there is one mode of therapy which has been proved by the efficacy of it is proved by repeated randomized controlled trials, it is CBT. In fact, CBT is sometimes considered also as one of the first line of treatment for OCD. So the question as to CBT for OCD, why? Why can't I just I can just take medication as SRIs, or SSRIs are sufficient. I just pop in a pill, and if that's going to take care of my problem, why do we go in for CBT? So what's the evidence? It's not about me telling, but what does the research evidence say? Okay. So CBT as a first line of treatment option is something which is largely suggested by different researchers across the globe for quite some time now. CBT with a combination of ERP has shown to be efficacious in the treatment of OCD. ERP, which is called the exposure response prevention, it is the most important component along with belief modification, which is what is cognitive restructuring. So if you look at it, a lot of times people who have mild to moderate levels of OCD, certain researchers have suggested that CBT alone can take care of it. If you would also, considering you're all mental health professionals, you would also understand sometimes people come to you and say that, no, I don't want to take medication, but is there anything that only therapy can do? So in case of CBT, when it is mild to moderate levels, CBT only has also shown efficacy in certain studies. The other part is when there is a question of severity, when people have severe levels of OCD, a combination of pharmacotherapy and psychotherapy, specifically CBT and SSRI, a combination of them have shown to respond a lot better. coming to the next part, which is, all right, so now that we've established that, fine, okay, we do CBT. Well, I think the other reason, which I probably have not mentioned here, which I also wanted to talk about, is that, well, medications do a large part of, let's say in case of people with severe levels of illness, a large part of bringing down your biological anxiety is done by medications. But after that, if there is a way that a client will have to handle obsessions, if they need to know the strategies or skills of how, even besides the medication, what are the coping strategies I need to handle it, or what is happening inside me. So even an understanding of the problem and what are the ways to handle it itself might be a very therapeutic way of handling it. So that way, medication takes care of the biochemical imbalance, the psychological balance in terms of the skills, the coping, the strategies to overcome these problems is something which, which a therapy like CBT can help.
Sorry to interrupt here.
Yeah.
So how do we know that if a person is suffering from this illness, mild or moderate or severe? What is the
Right.
level of measurement?
Yeah. You have a scale. It's like a gold standard scale, which is called Y-box, which is the Yale Brown Obsessive Compulsive Scale, Y-box. Okay, you can just Google up and you'll have it. So that's like a gold standard assessment measure, which will give you ratings of minimum, in fact, non-clinical, then minimal, or mild, moderate, severe. So there are cutoff scores for each of them. So that will give you the severity of the problem. In fact, Y-box gives you a symptom checklist scale as well as a symptom severity scale. When I say symptom checklist, it's a wide variety of different, obsessions and compulsions a person has, and you need to tick which are the ones you have. So that will give us, understanding of what specific obsessions and compulsions my client has. And then after that, we do a symptom severity as to, okay, in these of, let's say, of 20 of these, my client has only about 5 or 6. Now, of these 5 or 6, what is the level of severity of impact is what the severity scale will do. Okay. So having answered that, I'm moving on to the next question. Well, I think Tanushri is asking, can you share the name of the scale again? It will come up in the subsequent slides. Y-box, okay? Y-B-O-C-S, Y-box scale. Components of CBT for OCD. So, what involves that? There's so much spoken about CBT, it's efficacious and things like that. So what exactly it involves? Now, a therapeutic program for CBT for OCD involves largely 3 phases, as you see here. Phase 1 is engagement. Phase 2 is intervention. Phase 3 is termination. So if you look at phase 1, phase 2, phase 3, this is the general format for any form of therapy. If you take, you have the engagement phase, you have the intervention phase, and then you have the termination phase. But what goes into each of these phases is specific to CBT and OCD. So in engagement phase, as you see here, the goal is formation of a therapeutic alliance and to gather information for case formulation. Now from here on, what I'm going to do is that as you see the theory, you will also see a practical case which is discussed simultaneously. So we will go into the details of each of them as you start seeing the case. Okay. So formation of a therapeutic alliance. The second thing is to gather information for case formulation. So that is what happens in phase 1, which is engagement. In phase 2, which is intervention, what happens is that once you have an understanding of the client and the problems, you give them an understanding, which is what we call a psychoeducation. You explain the rationale for CBT, you prepare the client for ERP. The ERP and cognitive restructuring actually happens in the intervention phase. And intervention phase is usually the longest number of sessions. Okay? And the third phase is with regard to termination. Termination is that you look at how necessary it is to continue active treatment or not, which will largely be based on a post-assessment. And of course, the relapse prevention strategies of how you reduce the chances of the client to walk back into a therapy room. Right, so let's pair up the theoretical discussions with a clinical case discussion. Now, let's start with phase one. What happens in the engagement phase? So it's usually done between the first and the second session with and the aim of it is a pre-intervention assessment. So when we say pre-intervention assessment, it's your case history taking, your clinical interview, as well as in terms of any assessment that you have to do, that also is included in the engagement phase. So the tasks involved, if you look at it, is for this client, the first task was formation of a therapeutic alliance. So how it was done? Asking the client to talk about what brings them here. So how can you help, or what's concerning them right now is a good way to start off a therapy session where gathering information for understanding of the case. So here, the client in the first two sessions, we also, what is described to the client is that summary of the session structure as to how the session goes, where we start off with, the summary of the previous session and then set goals for the current session and how we go on. Any clarification and queries about it is taken. An overall outline of what the client can expect of ERP was explained. And of course, the most important thing is CBT is a collaborative approach. When I say collaborative approach, I do half, you do half, which is there's a lot of a collaboration between the therapist and the client, which comes forth. So homework assignments is a very, very integral part of CBT. Now, the client sees us just for 1 hour, but a large part of their time is back at home. So CBT largely banks on what is taught during the session is something which is practiced back at home. So the importance of homework task compliance is told at the beginning of the session. In fact, there's huge number of research to also support this, to say that prognosis is basically what is the success rate or what is the extent to which a client can recover. One of the predictors of prognostic factors of a client is also their compliance to homework assignments given during the therapy sessions. So this is what is done, as a first step. The second step is also looking at collecting information for individual case formulation. Now you might wonder, what is case formulation? Case formulation is nothing but, now let's say when a client comes to you, the first question that they have in mind after telling their history is, why am I having this problem? Like, what's the problem? I mean, why am I having this? My brother doesn't have, my father doesn't have, my mother doesn't have. Why is that I'm having? So as a therapist, we have the responsibility to help the client understand what has been the evolution, the possible cause. We're not saying that you're going to be 100% sure, but you're going to give the closest possible hypothesis to help the client see, yes, maybe this is what has happened. Okay, so for that, understanding of the client's context, the baseline assessments, and of course, verbal reports of family members also can help us understand an individual case formulation. The client whom I worked with, I'm also presenting the case formulation of that client in the subsequent slides. So you will understand how a case formulation for, in CBT is done. So at the end of phase one, this is what, this is the information that I had with the client whom we are going to discuss for the rest of the presentation today. So as you see, the case summary is that of Mr. A, who is a 27-year-old male who is working as a computer engineer, unmarried, from a middle socioeconomic status. So he's been having this problem for the last about 3 years, with an insidious onset, continuous course, and a progressive in nature problem. So what precipitated this problem, if you see, was a failure in a work project that he was currently posted in. He came with complaints of pathological doubts Whether did I make a mistake? Constantly. Whether did I make a mistake? Have I done it correctly? Is it done properly? So constant pathological doubts. The second thing is repeatedly reading. Yes, I know I've read this paragraph, but repeatedly reading again and again what has already been read. Rechecking. He's done a program, but repeatedly going back and checking whether he's done the coding right, not once or twice, but it was to an amount of he was doing it almost 30 to 40 times, checking a coding program, which was getting to be very exhaustive. Counting, which is I need to be sure I have not made a mistake. So he ends up repeatedly counting. So Word docs, coding sheets, spreadsheets, all these, he has a specific number. He had to count them this many number of times. Only then he was satisfied. So counting was not 1 or 2 times. As I said, in certain instances, it was 50 times. Certain instances, it was 20 times. But in any normal case, you see that 20 times checking a document is still excess when compared to what a normal person does. So when there's so much of time and effort invested into this compulsion, what happens? There is a delay in your performance. There is an exhaustion with regard to how much you can continue doing this. There is an excessive level of anxiety which is making you concentrate or perform your work properly. So because of this, what the client started doing was that he started avoiding going to work due to fear of making a mistake. In fact, first he started avoiding work. He was going to work, but he started avoiding work due to fear of making a mistake. Now, this client had a very interesting turn of events. So the turn of events was that on one side, it was about fear of making a mistake. But how did, out of the blue, he started having contamination obsessions, cleanliness related obsessions. So here the client also reported of fear of contamination post a period of brief illness. So what happened here was that the client was beginning to wash his hands repeatedly again and again and again, taking longer time for bath, washing the floor, bathroom, toilet repeatedly to ensure it was being clean. When I say repeatedly, it's not once or twice. The entire ritual was lasting for almost about 2 hours of bathing time alone. So for this particular client, so one of his cognitions was that I must be clean so that I don't fall sick. If I fall sick, then I will not be able to do my work to the best of my standards. So be it cleanliness or making a mistake, everything boiled down to I must be the best. I must do my best. So it came down to his performance. So inability to go for work as the above tasks kept client fully consumed as the number of obsessions and compulsions increased. So with these complaints, the client currently presented for treatment. Now, a very, very known psychiatrist called Dr. Kalyan Sundaram, he was one of my teachers in my journey in mental health. He very beautifully put it about how do you understand a case? How do you understand a client? Or how do you write a case history? It is more, it is almost like writing a crime thriller or writing like a thrilling novel. It's like you are collecting all these informations to have an understanding of why this client has come to you with these set of problems at this point in time. So as I'm reading through this case history, try to make a picture of what you have about the client. So the client also came with a family history of OCD, which was undiagnosed and untreated in father. There was perfectionistic traits in mother and father. There was high parental expectations from both the parents, where largely from the father, maybe lesser from the mother. So here, if you see, acceptance was contingent on achievement, meaning to say that if I did well, I will be liked. Because as a child, as an adolescent, when he scored well, when he did well in school, when he got, great marks, he was extremely encouraged and accepted by his parents. But when he did not do well, or when his scores fell even slightly short of it, there was a lot of criticality and punitiveness from the parents. So it sort of brought about underlying, understanding for him that I will be liked only if I do well. So if you need to succeed in life, you must be the best. So these are some of the thought processes that evolved as a result of high parental expectations during his childhood. Even in his personal history, what is suggested is that both teachers as well as work colleagues used to look up to him. This guy is so perfect, how well he does it. So perfectionism was repeatedly, again and again, being the best was repeatedly recognized and appreciated, both in both at his home, at school, work, everywhere that he went. If you look at before he developed pre-morbid personality is before the onset of the illness, what sort of a personality that the client had. So Mr. A was introverted, very achievement driven, highly organized, and gave excess importance to cleanliness. He also had a high concern over doing things perfectly and was very specific about not making a mistake. Like, for example, certain things that he voiced out was, I must be thoroughly competent in everything I do. I want to be perfect. I don't want people to talk bad about me. He also set very high goals for himself, very high personal standards. For example, mistakes is not a good thing, makes one look like a failure. So even a small mistake, he was not tolerant about it. Okay, so he was tolerant about mistakes other did, but he was not tolerant about mistakes that he did it for himself. So with all the above data, the client was diagnosed with OCD mixed type. When we say mixed type, it means that he has both obsessions as well as compulsions. So far was a rich information about the client, what came up in the client's history taking and clinical interview. In addition to that, in phase 1, it was also supplemented by Yale Brown Obsessive Compulsive Scale. Tanushree, that's the name of the scale that you had asked about. So that's Y-box scale. So
sorry to disturb, ma'am. Is he coming under the category type A personality then?
Sorry, type A, yeah. Type A, type A is more the driven type, right? Yeah. See, a personality assessment was not done for him because this can only be a sort of a presumption that, he comes under type A. But if you look at the feel of it, somebody who's quite anxious probably comes into that scale. So I will not commit to it, but well, the hypothesis could support that. Okay, so pre-assessment, what was done was Y-box. So the Y-box was done on 27th of March 2019. The obsessions were on a score of 15, compulsions were a score of 15. The total was 30, which was severe levels of OCD. Okay, and in addition to that, there was a need to also assess his emotional disturbance level in terms of mood, like, because of course, Y-box gives you the anxiety rating, but of course, with regard to the depression, the reason was he was not going for work. He was away from his occupational engagement. So is there any sort of an underlying depression, which is a very common comorbid illness that people with OCD also have? So in that, he scored 16, which was mild levels on BDI. So with this data, of course, there was one more, scale, which provided a wealth of understanding about this client. Because let me tell you, if you're going to do, if we are looking at CBT as a way of, handling a client for OCD, there is no point in us rushing into, okay, let's go on with ERPs, let's go on with cognitive restructuring, because your strategies are nothing without a proper understanding of what we need to work on. What are the cognitions we need to handle? What are the core beliefs we need to handle? So that way, a good amount and effort of time and effort needs to be spent on assessment. When I say assessment, you don't even have to do a elaborate set of questionnaires. No. This was just about 2 questionnaires and 1 clinical interview, spanning 2 sessions, that's it. But it gave a very good wealth of information. So this is another scale called NPS by Frost. Okay, so it's called the multidimensional perfectionism scale. Here, I'm just presenting to you some of the items which he scored strongly agree, which I felt was relevant for the case discussion. So I've just given you some samples of it. So as you see here, this client, he felt that my parents set very high standards for me. If I fail at work, I'm a failure as a person. All these gives you an understanding of what is running in his mind behind these symptoms that we are seeing today. So I set higher goals for myself than most people. I hate being less than the best at things. I tend to get behind in my work because I repeat things over and over. The fewer mistakes I make, the more people will like me. Now, what more than OCD do you expect from a person who's had this sort of a findings in phase 1? So leaving that phase 1 understanding, let's move on to phase 2, S2. In phase 2, I'm going to present as 2 parts, okay, the intervention part 1 and then intervention part 2. In phase 2, initially, the part 1 of the intervention is usually done around the 3rd to the 4th session. So here the aim is psychoeducation, which is, okay, the client needs to understand what is an obsession, what is a compulsion, how it works out, what happens inside me. So psychoeducation is important. Following that is case conceptualization. The client might wonder, you spoke with me for 2 sessions, I gave you all the information, you gave some assessment tools. What have you done with that? So what have we done with that? The answer to it is what we call as a case conceptualization. This is like giving the therapist understanding of what is happening within the client and getting a verification from the client to see, is this what is happening? Are we on the same page? It is very important to get to the same page between the therapist and the client, because thereafter, only when the client sees that, yes, this is what's happening with me, when the client has that understanding, is when you can even go forward. If the client feels that, no, something else is happening to me, there's no point in you going ahead at all, because that way there won't be any cooperation, there won't be any motivation in the client engaging in this. Okay, so case conceptualization is something which is very, very important. Okay. So going on to the 3rd part, which is the orientation to components of CBT itself. So as you see, the first task was psychoeducation. In this client, what was done was that he was psychoeducated about what is an obsession, what's a compulsion, what are safety behaviors that a client engages in, the prevalence of the problem, what are the causes of OCD. I'm not going into details of these things because it's like this is something which is quite understandable, and of course it's there present for you in most of the theoretical books, basic level books. Okay, so again, you talk to them about options of both pharmacotherapy as well as CBT being there, and you talk to them about the prognosis outcome. And then after that, we give them a rationale for as to why CBT is done. The rationale is that 40 to 60% usually they do respond to medication. For those who do not respond to adequate trials of medication, CBT is the next best alternative treatment. This is one explanation. The other thing is that when there's a combination of CBT and pharmacotherapy, so you needn't necessarily wait for being a non-responder. A combination of CBT and pharmacotherapy also speeds up the recovery process. So there are certain components of CBT, according to the Schwartz model. So there are 4 aspects of it, which you need to keep in mind, because this is what will take you through the therapy process as well. So the first thing is relabel. In case of relabel, the first thing is you're trying to get a client to understand that these thoughts, images, behaviors that you were doing, label them. It is just not some thought, some behavior, or some images. Try to help them to identify, yes, it's an obsession. Yes, it's a compulsion. The minute you do that, they have a sense of control about what's happening to them. So that's relabel. The second thing is reattribute. Often, now let's say, for example, this mother who came to me, she was torn apart because she was having obsessions of her 1-year-old child being thrown, into the truck. So there was a lot of guilt. How can I think of something like this? I mean, I'm such a terrible mother. So there's a lot of guilt because the thoughts were seen as self-generated, consciously generated. Now, when this process of reattribution happens, we try to help the client to see that it is not because you want to think like this. It is because of the illness. So the thoughts are seen as a result of illness and not due to a character flaw. This helps the client to reduce guilt or, reduce the personal responsibility they take upon themselves for a big, catastrophe to happen. And also sometimes when you are able to put the thought out and analyze, you become an objective spectator. When you have to keep the thoughts inside, it becomes too emotionally draining for you to do it. The third aspect is refocus. Refocus is very often, one of the very common things is obsession. Distract yourself. Don't focus on the thoughts. But on the contrary, refocus is a very, very opposite approach where they ask the client to actually focus on the anxiety. This has to be done with a great amount of skill because when you're asking a client to focus on the anxiety that they're experiencing, we better well know how to handle them and how to help the client to handle them. Because otherwise, we're going to get the client to focus on the anxiety and not equip them how to handle it, then it's going to be a huge catastrophe. So here, this refocusing is one of the basic strategies or basic principles behind ERP, where you get the client to expose them to the anxiety-provoking event. Now, let's say, for example, you expose them to not checking the lock again, not checking the gas stove again. Experience the anxiety, tolerate it, and then see what happens. Okay? And then, of course, the fourth one is revaluing, which is the minute you understand your obsessions are just merely symptoms of an illness, they become less significant and less noteworthy. The minute I feel that it's me who's thinking so bad things, it's me who's having such horrific thoughts, then in that case, it becomes a lot more distressing. The minute you dissociate it and say that, hey, it's just my illness, it's not me thinking, it is less significant and it becomes less noteworthy. So here's the much awaited case formulation of this client who we've been talking about it for, in phase 1 and in phase 1 of it. As you see here, this basically is 2 slides. Okay, so, I was not able to fit the whole thing into the same slide. So I've just presented as a continuation. Please bear with me. When we are looking at a cognitive behavioral approach, these headings you can keep in mind and see how you can fit whatever you have got from your first 2 phases, from your phase 1, which is based on your clinical interview assessment. Whatever information you've got, see if you can, where you can fit these information into. Okay. So for Mr. A, if you see the headings, it is, there is certain relevant life history which influences a person's core beliefs about themselves. And these core beliefs gives rise to certain dysfunctional assumptions, attitudes, and rules which guide our behavior. Now, when we face a situation or a trigger, what happens is that there are a set of automatic thoughts that gets triggered off. Now, these automatic thoughts in turn gives rise to a set of emotions, physiological response, as well as behavioral response. Okay. A 1-hour session in CBT for OCD is definitely not sufficient for me to explain this entire thing. Maybe we'll keep it for a later time, but let me go into specifically understanding for this client what happened. So the way I hypothesized this client's case was that Mr. A, he had an introverted personality as well as a perfectionistic personality. The high parental standards as well as a family history of OCD in father, success being largely dependent on whether you achieve or not, parents being perfectionists themselves, And perfectionism itself being as a very desirable life value portrayed by his work colleagues, by his teachers, everybody around him. So all this life history together has probably made him form a core belief about himself that I must be perfect. Perfectionism is success. Mistakes means failure. So these could be certain core beliefs that the client has developed. Now, these core beliefs in turn gives rise to certain negative dysfunctional assumptions. How do you, the clue to understand this is it's if-then statements. So if I make a mistake, then people will look down upon me. If I'm not perfectly clean, then I will fall sick. If I need to be successful, then I must be perfect. So these sort of if-then statements are certain conditional assumptions that the client started to make for himself. Slowly, what happened? When there was a trigger or a precipitating event, such as a failure in project and thereby negative remark by his seniors, what happened? A surge of negative automatic thoughts started to surface. I should have been more careful. It was my mistake. I have failed. I cannot succeed ever. If I had checked the project well enough, I would not have failed. I should not miss anything hereafter. I must check whatever I'm doing so that it's done perfect. I must check whatever I'm doing is done perfectly or not. So when this sort of a situation happened, these were some automatic thoughts that started, coming up to him. Now, when these automatic thoughts happened, if you remember the previous cycle, which I described to you about Freeston, so there is a situation. So if you remember that cycle, we actually started with the situation, thoughts, and emotion and, compulsions. Actually, what happens, one of the participants asked whether early life experiences is what that decides, the thought process. Yes, if you look at here, now in this situation, why is that Mr. A had these automatic thoughts? Because of his relevant life history has contributed certain core beliefs and conditional assumptions which has been dormantly lying within him. And when a trigger happened, it burst out to a set of automatic thoughts, which in turn gave rise to anxiety in the form of physiological responses as well, like stomach churning, raising heartbeat, a lump in the throat, which in turn led to behavioral responses, which is nothing but compulsions, which is started rechecking, rereading, counting, washing, cleaning, and so forth and so on. So this was the hypothesis given to the client, which the client readily understood and accepted and clarified that, yes, probably this is what is happening. Because only when this is given, we are on the same page with the client. Okay, so if you remember the same cycle which I said earlier, let me explain it specifically with this particular client. So what happened? So coding a program. So now let's say in this client, when he has to sit on the computer to code a program, suddenly the thought is that, am I doing it correctly? The cognitive appraisal is that if I make a mistake, then the whole program is a failure. So he gives excess importance to, am I doing it correctly, is a normal thought anybody would get. But this particular client gave it excess importance by saying that just if I make one mistake, then the whole program is a failure. So because of that, the anxiety increased. Because the anxiety increased, he started rechecking, redoing, and counting the number of times he was checking it. So only when he did this, his anxiety reduced. And again, he coded a program, the same thought came, and it became again and again a vicious cycle. Right. So if you looked at it, phase 2, I said one was case conceptualization. The other thing was psychoeducation. Psychoeducation is just not about knowing what obsessions are, what compulsions are. Psychoeducation is also about understanding, what actually happens in ERP. People might wonder, I mean, you've been talking about ERP for a long time. What exactly it is? What's happening? So here, if you look at it, let me tell you, the chart in front of you is not ERP. It is what that happens before ERP. Okay. So this is what happens when the client has not started treatment. As you see here, the thought occurs, and then when the compulsion is performed, temporarily the anxiety goes down. But again, the thought comes, anxiety goes up, anxiety comes down, anxiety goes up. So it just keeps on, the thought returns, and then it just keeps on going as a pattern, and it keeps on increasing. As you see, there is an upward curve. So thought happens, neutralizing, and then the thought returns. So as you see, it's an upward curve. On the other hand, in ERP, what are we trying to do? Is this. Now, this diagram is something not just the therapists need to understand, but it is something that you need to sit with the client and explain to them. Where when you start, ERP is nothing but exposure response prevention. You are exposing the client to the anxiety-provoking situation, but you are preventing them from engaging in the compulsion. So you're asking them to watch the lock, but you're asking them not to check the lock. You're asking them to see the gas stove. You're asking them not to check the gas stove. Okay. So meaning to say that when you are exposed to that trigger, when you're exposed to the trigger, initially there is an increase in the level of anxiety. Okay. And then it reaches a peak. When it reaches a peak, it plateaus. Plateaus in the sense, it stays on in that same level of anxiety for some time. And after some time, even without doing the compulsion, your anxiety automatically takes a downward curve and comes down. Very often I quote the example of, pushing someone into a dark room who's scared of ghosts. This is the example I give my clients as well. You're scared of ghosts. Okay, you don't want to enter the dark room, but let's say you're pushed inside the dark room. Initially, your anxiety shoots up. It will stay very strong for a period of time. It stays in the peak, especially around the 12 o'clock, 1 o'clock in the night for whatever the movies represent. Either 12 o'clock, 1 o'clock ghost comes or 3 o'clock ghost comes. So around that time, the anxiety is something which plateaus after a point in time. Let's say when a person enters the dark room, they will feel anxious. They will continue to feel anxious. But if you actually ask them, now let's say around 12 o'clock or 3 o'clock in the night, their anxiety might be 90%. But morning 6 o'clock, or let's say morning 5 o'clock, do you think the anxiety is going to be the same as 90%? It's not possible, because any biological drive that goes up has to come down. Be it your sleep, appetite, your emotions, your sex, whatever it is. Any of the biological drive, the tendency of it is they increase, they go down. And that's the whole basis of ERP, where even without you performing the compulsion, your anxiety will anyway go down. Now, that is something that the client doesn't have the confidence to do it at home. And that's what ERP helps them to do it here. Okay. Now, this is another example. This is actually, these are all process of, what you do. Now, as part of the intervention strategies, you also start setting what we call as a graded hierarchy of, when you do ERP, you need to start looking at what are the ERP, exposure exercises you need to have for them, right? So you get the list of what are the situations that provokes anxiety for them. What are the obsessions? What are the compulsions? And what is the anxiety experience? SUD means subjective unit of distress. What I experience as a distress. Now, in this client, after he had a period of illness, he started feeling that, he has to be perfectly clean. Only then he won't fall sick, and thereby he can keep up his best standards of work performance. So he started having, so this is actually a graded hierarchy from his, therapy. Now, as I'm talking to you about this client, let me also, issue a disclaimer that the client has been spoken to, and the case discussion was previously taken permission and consent from the client before discussing all of this for academic purpose. Okay, right. So as you see here, these are the trigger situations. So after visiting the toilet, the obsession he has is, are my hands clean? The compulsion is, washing hands for about 25 to 30 minutes. So the anxiety is about 65%. So similarly, as you see here, opening tap to wash hands while entering bathroom, taking bath, what are the obsessions he had? What are the compulsions that he does? As you see here, he used to check water by allowing it to run free for 1 hour to see whether the water was contaminated or not. To an extent where, because they lived in an apartment, there was problems with water for their flats as well, a smaller place. So how it affects, other people also around them is an example of this. So as you see here, he used to wash the floor taps, latch, faucet, toilet seat, all with 10 cups of water. He has to count 10 times he has to wash. Only then he feels that it's satisfied. And again, his bathing used to take a total duration for about 2 hours. So we order them according to an increasing level of distress. ERP, we always start with, I've given you just 4 of about 10 to 15 trigger factors. So this was just a sample. His lowest was as low as about 35 or 40. So you usually start ERP with the least anxiety provoking task. Okay, so phase 2, which is the intervention, which is usually the 5 to 15 sessions. Here, what we do is, you've already explained the client what it is. So here you actually go on to do the exposure response prevention and cognitive restructuring. So here what we do is that when you're doing ERPs, of course, if the client comes by themselves, that's fine. But if the problem is a little severe, it would be good for you to identify a co-therapist, somebody who stayed with them at home, because they need some support for following this ERP and practicing this back at home as well. Now, in my client, his mother was the co-therapist, and the ERP was initiated based on the graded hierarchy set according to the subjective unit of distress. So here what is done is that in the client, what was done is that the client was asked to, write a piece of coding, and then the client was asked not to check it. Despite him having his level of anxiety going up, he was asked not to check it. And then as the time and the anxiety level were monitored once in 10 minutes and given as a feedback to the client, where the client noticed, just like how the ERP graph is shown, the anxiety increased, it stayed at a point, a constant. And within, let's say, even about 45 minutes to 1 hour, the anxiety started decreasing. But let's say for more complex compulsions like bathing, for him, it took even about 2 hours for the anxiety to come down. It can even take as long as 3 hours sometimes. So it's not that within 1 hour, your ERP gets over. It's not like that. Always have some time allowance for that to happen. So the whole point of ERP is that the client experienced and realized that distress will come down even if compulsions are not performed. With time, when compulsions are not performed consistently, the time taken for distress will also keep reducing. So that was with regard to ERP. With regard to cognitive restructuring, if you see, one is behavioral strategy, the other is the cognitive strategy. In case of cognitive strategy, 2 main things we do. One is first help them identify the cognitive errors. The second thing is help them challenge these negative automatic thoughts. So in case of cognitive errors, there are a list of cognitive errors. Some of the ones which this client had is that, now let's say I'm just taking one statement. In that one statement, you see how many cognitive errors are there. I feel I'm a failure when I make a mistake. I feel I'm a failure is emotional reasoning. Jumping to conclusion, just because I make one mistake, they're jumping to conclusion that, he's a failure. Selective abstraction, he's looking at only the time when he's made a mistake. He's not looking at all the other times he ran a program successfully. So how just one statement can have a list of cognitive errors. In addition to this, so this is just one. We need to do this for a lot of the thoughts that the client is voicing during the therapy, helping them identify what are the thinking errors. And of course, after that is orientation to challenging of negative automatic thoughts, where how do you challenge these negative automatic thoughts? Earlier, a thought came, we just blindly accept that, yes, it is true. And that's why we end up feeling anxious. But now, when the thoughts come, we say that, hey, these are thoughts with illness. Let me first see whether it's logical enough or not for me to even act on it. So how do I challenge is, are you confusing a thought with a fact? These are some questions. What would I say if your friend was in the same situation? So this is another strategy called as double standard. So these are like different forms of cognitive errors or thinking errors, and these are also some of the ways how to replace them. So as you see here, on the left is thinking errors. What are they called and how it impacts and how you can replace it. Because of the shortage of time, I will not be able to go specifically into this. Of course, this is available for you online as well. Okay. The other strategy, which was so ERP, cognitive restructuring, behavioral experiment. These three forms the crux of CBT for OCD. So in case of behavioral experiment, as the name suggests itself, what are we doing here? We are testing the negative predictions of the client. Now, in my client, what I did is that we experimented for coding without repeated rechecking. So your ERP also becomes a behavioral experiment. So what he understood was that I still got the coding right, even without me rechecking. So the thought was proven, or the prediction was proven to be merely a thought and not a fact. Okay. So coming to phase three, it was a time for termination as well, because a lot of these therapist-driven ERPs were translated to the client-driven ERPs, where the client practiced these quite well at home as well. The client responded quite well to both cognitive restructuring, ERP. He was very compliant as well. So about 3 sessions were used for termination, where it was for post-assessment and of course relapse prevention. By then, his depressive symptoms also, were quite obviously, not in place. So there was no need for us to do the PDI again. Largely what was done was with regard to reevaluating him on YBox. So as you see here, in about 3 months' time, so from March to June of 2019, from severe level, the client was able to come within mild levels of the OCD problem itself. So following this, it's one thing we should remember, we should not forget, is relapse prevention, which is you need to continue doing the self-driven ERPs. This client continued doing that. It became part of his routine. It became part of his habit. He also tried avoiding the proxy compulsions, which is getting his mother sometimes do compulsions for him. Also looking for early signs. Largely his compulsions came down. Even when they started coming back again, when early signs were detected, apply the techniques already learned was what was reinforced. And also when earlier a large time was spent on obsessions and compulsions. So what happened was that the time spent on productive activities became very minimal. Now, the more time you have, the more space OCD comes and sits inside you. So what was done was that, a lot of time on getting his productive activities back in place, getting him back on job, on certain small tasks was started. And of course, booster sessions continued for about 3 to 4 months. With this, we wrapped up CBT for OCD in this client who suffered the problem. So, well, I think the time is also running. So coming to the end of it, that's about my presentation. I think this is the best I could do within the given time I had. So, yep. So any questions?
Thank you so much, ma'am. It was very nice. One question, ma'am. So the end of termination. So we have 4+4, right? So 8 that should be fine, or we need to reduce, or it can't be completely reduced.
The actual cutoff in YBox, if you see, sir, is 0 to 7 is actually non-clinical. 8 and above 8 to a particular level is mild. So if we can bring it from 8 further down, now let's say if I continued, let's say to assess him after 3 or 4 months, we don't know whether the score remains the same or has come down or gone up. You can still try reassessing him, even after that, no problem. But the minute he comes to 7 is as good as, a person who is not anymore, diagnosable as a client with OCD.
Thank you.
Thank you so much, Sati ma'am. It was.
What is the number of sessions one need to undergo for treatment of OCD?
Sir, can you kindly wait for a minute? Thank you. Can you hear me, Selvi ma'am?
Yes. Okay. Because of this, I'm not sure who's talking, but I'm just going to respond to what I hear. Yeah. Okay. Yes.
Chandra here.
Yes, Chandra ma'am.
Thank you for your overwhelmingly impressive presentation. It
Thank
was
you very
lovely.
much, ma'am. Thank you so much.
And can't have words to explain the flow you made today.
Thank you so much. Thanks a lot.
This is officially the space for the participants to discuss. So I would request the participants to make your questions quick and we can go for a discussion and then we will conclude the session, ma'am. Yeah. So now we also have some questions in the chat box, ma'am. Maybe before that, if somebody has to unmute and talk, kindly do it and we can take the questions later in the chat box.
Yeah, thank you. This is Sujata here. I would just like to know, CBT works for people who do not talk at all, in the sense like very, and who are in the denial. Does it work for them?
As a therapist, I think the primary responsibility is for you to understand why the client doesn't talk. Unless and otherwise they have a selective or an elective mutism, there is a reason why the client is not able to talk. So probably breaking the barriers, getting them to talk, because as you see, CBT is largely based on the thoughts, the thought processes. So it's important to get the client to talk. Now, there's also, like the other strategy that you can do for a client who is not upfront. Now, let's say this client is a little guarded or they are not willing to open up much. For such clients, start off with a questionnaire. A questionnaire will beautifully give you points to open up. So you can, let's say, now, for example, MPS, multidimensional perfectionism scale, I can give first for a client and then pick up items from that and say, sir, you've mentioned something like this. So can you tell me more about it? So psychological assessments definitely help you to open up clients. So if that answers your
question. Thank you so much.
No problem. Yeah.
Anybody would like to unmute? You can go ahead before.
Hello, ma'am.
Yes, ma'am. Yes, shoot your question.
Hello, ma'am. Am I audible?
Yes, you're audible. Yes.
Yeah. Ma'am, I have a doubt. So that I wanted to first thank you, because see, when we hear about OCD, we only know about cleanliness, now repeatedly doing a behavior. But today, when you shared about one of the obsession as defecation on godly figures, right?
Yes.
Because this today only I came to know that it is also an obsession, because one of my friend long back, I heard that she had a problem telling to me that especially when she's toileting, right? That time, she gets the thought of that as if, on a godly statue.
Yes.
Defecation.
Yes.
And also when she's seeing the Abhishekam, right?
Yeah, correct.
And the Sami Abhishekam pannuvangala, like
correct.
When she sees that video or somewhere in the TV also, and the palo illa that chandanam, which is yellow color or something, she gets the thought of something like that defecation is happening onto God.
Right.
Because when she said, I definitely didn't know that it is. And when today you said only, I knew, because even I didn't know what was the reason. I was not able to help her. But today, when I just wanted to help her, if you can just tell what could be the closest hypothesis of that, why she would get that thought of that specially defecation on godly figures, and how can it be helped?
Dr. Vidya, number one, I'm happy that the session helped you to identify, a symptom as a symptom itself. One. The second thing is that just because she has, now let's clarify, there's a difference between OCD and OC symptoms. So the difference here is so the difference here is sadness and depression. Just because a person is sad does not mean that the person qualifies for a clinical depression. Now, just because a person has certain obsessions does not mean that the client has OCD. So if you remember in my presentation, I had mentioned to you as now, let's say when she sees the gods portrayed or when she goes to a temple, these sort of a random thoughts come. So which means she has, let's say, these random thoughts of obsessions, which needn't necessarily qualify for an OCD. But in certain cases, if it is left unchecked, if there are more distressing thoughts adding on, it has the risk of eventually ending up with a clinical diagnosis like OCD. So that way, in your friend, I'm not sure whether she is just at the symptom level or at the clinical condition level. The third question that you asked is with regard to, can I hypothesize as to why she's having this?
Yeah.
I would be happy to hypothesize only after I have had 2 sessions with your friend.
No, generally, theoretically, we would know, right? Such thought. Theoretically, at least.
See, with regard to theoretical, there is no blanket sort of a blanket statement which we can say that this is why the person has these sort of an obsessions. No. Okay, of course, you have the psychodynamic approach which looks at it very differently. But when I am sticking on to a cognitive framework of it, unless and otherwise I look at the cognitive background of the client's history, what has shaped it is what will give me a right hypothesis. See, a hypothesis, I can just give it to you, but it has to have some validity in me basing it on this particular client's, history. So I would
maybe that
refrain from
also
it.
is a unconscious pattern, like maybe something has happened. Maybe that is in her unconscious, subconscious.
In cognitive models, nothing unconscious.
That
Everything
is
is
what
conscious.
that is what I wanted to know. In cognitive perspective, what would be the reason?
When we say unconscious and conscious, it is not to say that, see, when we say unconscious, it's not to say that it's not something that the client is completely blind to. Now, if you ask them to talk about their past history, they will be able to talk about it. They'll be able to talk about the parenting, perfectionism, high standards, etc., etc. So, which means they are aware of it, but they are not conscious of how the entire thing is contributing to their psychopathology in the current day. So that's the part where they lack awareness.
Because yeah, if I could, please don't mistake me, because what I wanted to help her, because when she felt it so distressed that she was sharing it to me is she stopped watching Abhishekam all, like even in TV, because she is getting it now often.
Right.
And
can you see here?
Toileting.
Can you see here? It started as a random. Yeah, it started as a random thought, but now slowly there is a dysfunction being, there's a dysfunction that's seeing where she's stopping to do her routine. She
changes the TV.
Yeah.
Abhishekam, she doesn't watch it, the toilet things. And daily toileting itself, daily when she toilets, right?
Right.
Daily she's getting the thought, it seems.
Okay. Dr. Vidya.
Help, right?
See, I don't know where your friend is based out of, but Ahana Hospital. Oh, she's based out of Chennai. Okay, fine. Then I have to be okay. Of course, I'm based out of Chennai, but you also have a lot of other able people who are here in Chennai, who are colleagues who can.
Maybe I can tell her to contact you.
Yeah, most welcome to do that. Sure, definitely. Yes.
Sure, ma'am. Thank you so much. Thank you so much that today I got an insight that this education is actually a part of it. Thank you so much for that info.
I'm glad it did. Thank you. Yeah.
Thank you so much.
Ma'am, if we have to have a session with you, one of the patients want to be with you, it should we come to Madurai, or is there an online session also?
Madurai, we have a beautiful team. Ahana Hospitals is a fantastic team of mental health professionals, where Dr. C. Ram Subramanian, Dr. Vikram, Dr. Ganesh Kumar, we have a wonderful team of psychiatrists and psychologists as well. There is another Dr. Selvi who presented just a few sessions back on resilience for children. So she's also somebody who is trained in CBT based out of Madurai. So we have very good team of psychologists in Ahana who can take them up. Yeah.
So there is no online.
Well, online.
No.
I'll tell you.
We are based in. See, I must be the only person who's not a doctor in this team. I'm a counselor, but I'm looking at from my entire family has got this OCD, and it is a distress for the people who are around them. So I was just looking for so long, that's why I logged in. So I wanted to know, OCD specialist, like, so in case I need to, like, we need to come, what do I do? Without coming to Madurai, is there any other option?
Where are you based out of, Sujata, ma'am?
Chennai.
All right. Chennai. Okay, then you.
I am in this group, psychology group, because like,
right,
I happen
fine,
to
okay.
be a career counselor. Yeah.
Okay, you can contact me, and I'll tell you either me or somebody else in Chennai where I know they do this, they can help. Because, I also have certain, limited, so I don't want to keep you waiting for too long as well. So because help should be immediate when we know there's a problem. So I'll see what best I can do. You can contact me privately, and I'll see what best I can do. Yeah.
Thank you so much, and it was
Most
a very
welcome.
good session. Thank you.
Thank you, ma'am. Thank you. Yeah.
So lovely.
Hello, good evening.
Sir.
Yes.
Hello, ma'am. Am I audible?
Yes, Madan Kumar, sir. Yes.
Yeah, ma'am. Ma'am, what about the sensory OCD, ma'am? Sensory motor OCD, possible to treat, ma'am?
Can you tell me what is sensory motor OCD, sir?
So focusing on that sympathetic nerve actions, that automatic nerves, we are focusing on breathing like this. Obsession on that.
Madan Kumar, sir, I'm not familiar with something called sensory motor OCD. I'm not sure of that.
Okay.
I'm not familiar with that.
Okay, ma'am. Thank you, ma'am.
No problem. No problem.
Selvi, ma'am, you can see that.
Ma'am, can I ask one last question, ma'am? Because already time is delayed. Sorry.
No problem.
One simple question I want to ask from my
Yes, Shiv Kumar,
experience.
sir. Yes, Shiv Kumar, sir.
Ma'am, actually, if from childhood, ma'am, how the upbringing comes, for a child, the upbringing from his childhood. Suppose in that family, if the child is given some values and ethics, which he is taught, and he will continue, in his daily routines and all. So at one stage of life, suppose he's not able to do all such things, the things which has been during his upbringing has been brought. So then in that case also the obsession may have, and he gets some anxiety if he is not able to perform that, and if he is not able to, because this is all a ritual thing which now he stopped, or he is distracted from that. So now if he wants, he's not able to compete, and he feels that, and he gets anxiety. So then we can call it as again obsession. And
Shiv Kumar, sir, you're very right in terms of a large part of upbringing, the values, rituals taught during early years can influence how a person sees obsessions as well. Now, one of my client, he had certain very stringent rituals that the family follows, and his belief is that if I'm a good person, I must do these. If I don't do this, then I'm a bad person. So
Correct.
because of that, what became as a ritual, it became as an it became a disorder. So
Yes,
even
ma'am.
if you see in that Y box checklist, rituals, superstitions, people who say that, okay, I want number 3 only, or I want number 7 only, or all these superstitions and rituals, when it crosses a certain point, causing distress, dysfunction, it definitely can. And of course, the criteria of spending about 1 hour an entire day, it can be categorized as OCD. Yes.
so why means again the parents, when he is not performing, the parents again and again they will be correcting him, means that kind of, you are not doing, you are not following and all. So by that way, now whether he has to listen to parents, or he is getting into OCD, all these things, obsessions will again problem. Because again, it is unaware of the parents, because parents, they are not doing any intentionally to the child. And child is also not doing instantly. So accidentally this obsession is coming, ma'am.
Right. In fact, a very classical example of what you just now said was a client whom I was seeing. He comes from a particular, culture where these rituals have to be followed. like let's say getting up, even keeping rice for certain things, or you have to do things only with this particular day, and a lot of these obsessions which ended up becoming very interfering. So at that point in time, the way forward we took with the client was that, see, helping the clients to understand that these are certain cultural practices which, when taken beyond a point, can result to a dysfunction. And if your parents have followed these cultural practices without a dysfunction, so be it. But if that is causing a dysfunction for you, you will have to draw a line as to where you need to follow, what you need to, omit. So one was that. The second thing, what I also did was that I included the family also in the psychoeducative process. Because on one side here, we are telling ERP, don't do it. The other side, back at home, they're like, what you're not doing? You are supposed to be doing. So educating the family that how certain things, when gone beyond limit, can take the shape of the illness itself. So that thereby we bring the family also as part of the treatment process indicators. So managing like that, at no point saying that your culture is wrong or your rituals are wrong. No, we should never do that, not demean a person's, cultural practices. Accept it, acknowledge it, but still see where certain lines or boundaries has to be drawn so that the distress or dysfunction can be averted.
Yeah. So thank you, ma'am. I got the exact answer, and it was very relevant. And I'm satisfied, ma'am. Thank you, ma'am. Thank you. With all your experience and research things, you could able to tell actually the way we have to handle such situation. Thank you, ma'am.
Thank you very much, Shiv sir. Thank you.
Thank you.
Ma'am, good evening. This is Sugandhi. Ma'am, can you please share your contact details in the chat box?
Yes, I think even in that Telegram group and WhatsApp group, they are asking your contact details, either email or phone number. Please do share here.
Yeah, sure, sir. Kandipa. After the program, I'll definitely do that. Yeah.
Fine.
You can see the chat box. All the positive adjectives are overflowing actually there.
Chandra ma'am.
Anyways, you can see ma'am, all dictionaries in only with all the positive words. But I don't want questions from the participants in the chat box go, ma'am. So we'll quickly take it up and then we'll wind it up. So the first question from the chat box is, how many sessions are required for the treatment? But it doesn't speak about what treatment, ma'am. So I don't know how you would take it.
I would assume they are asking about CBT, considering that that's the, presentation. See, you have brief CBT as well. You have brief CBT for about 8 to 10 sessions. You also have CBT, which is, a little longer. It depends on the severity of the problem. Now, for a person who has let's say, severe levels of OCD, 20-25 sessions can take place. So this is an average number. It can go up or it can come down as well.
Thank you, ma'am. The next question is, how do we mark the percentage of anxiety?
How do we mark the
percentage of anxiety?
The Vibox scale, which I said, the Vibox scale gives the cutoff scores where 0 to 7 is non-clinical and 8 to a particular number is mild, and then you have moderate, then you have severe. So there are 4 categories. Vibox scale gives you the level of anxiety.
Thank you, ma'am. The next question is, the client A being thinking type of personality, can we use REBT instead of CBT?
No, Chandra ma'am, sorry, come again. Client A, BR. What is it?
The client A.
Okay.
Being thinking type of personality.
Okay.
Can we use REBT instead of CBT?
Yeah, you can, no problem at all. RET is basically rational emotive behavior therapy. So definitely you can use it. There also we look at certain cognitive errors, maybe a little bit more focused towards emotions.
Okay, ma'am. Thank you very much. And one question was asking for an OCD treatment in Bangalore. Do you have any contacts? That's the last question, ma'am.
You have Nimhans sitting there in Bangalore. How can you ask? Well, Nimhans is a tertiary care center is right there. They have the behavioral medicine unit, BMU, behavioral medicine unit. So they can just walk into there and meet Dr. Paulami, who's Dr. Paulami, Dr. Manjula. All of them are senior consultants there.
Ma'am, we really respect the overwhelming feeling of the participants here. because we're still keeping on asking questions to you. The last question for now would be, what would be the time interval for OCD? I mean, the sessions, if it's going to be like 20 or 25, it's the one question asked by the participant. The time interval between sessions.
Sure. See, what I generally do is that the initial phase, let's say phase 1, which is engagement, and the intervention phase, where skills train, the assessment, psychoeducation, skills training, all of this, I keep it at least about twice a week. Because what happens is that, now imagine you meet a client once today, and then only after the, like next week, you're going to meet them for the next session of assessment or next session of psychoeducation, then it becomes too long. The initial process itself will be slow. So what I do is that until the skills training happens, I see them, twice a week, depending on the severity or their time availability, sometimes even thrice a week. And then once the skills training is done, because once the skills training is done, it's about them having to go back, practice, come back, go back, practice, come back. So at that point in time, I will phase it out to once a week again.
Ma'am, for your kind words, patience, and everything. Without wasting much of the time, I would like to request Dr. Salim, one of our core team members, to give his brief feedback. Salim, sir, at your go now.
Thank you, Dr. Chandra ma'am, for the opportunity for giving the feedback. It was a very wonderful session by the Dr. Selva Kumari ma'am. So we learned a lot about today's session, and we understood that CBT is a collaborative approach. So you rightly said, go back and do it again and again. So basically, success rate, it depends on the client's exercise homework. So that's what really we learned about like a real case history, phase 1, phase 2, and phase 3 engagement in intervention and termination. So we learned a lot, madam, and particularly question answer session, it was very well. A lot of people confused about OCD and OC symptoms. So they couldn't be able to draw the line between real OCD and symptoms. So you very well explained about sadness and depression. So which one is OCD and which one is symptoms. So, and we got very clear and symptom level and clinical condition level. And of course, that a model of cognitive OCD, like appraisal and from the compulsion to reduce the anxiety, and the model particularly talked about first and 1997 cognitive model. So it was a very good explanation by madam, and you clearly explained about when it is beyond the normal. Like there are 3 bullet points you mentioned, and it will be very helpful to all the counselors and who are the practitioners, like controlling difficulty and socio-occupational and brief relief. So lot thing, and we got one things, madam, like a combination of biological treatment and the psychotherapy. It will be the good combination to come out get the success rate, I believe, and pharma therapy like SRI and SSRI plus CBT. CBT or REBT, in the someone recently asked about whatever. So this combination will work out. So it is better we have to go for the combination of biological and the psychotherapy to get the result, I believe. I think so. So however, psychologist counselor role is very, very important to give the 50% of the psychotherapy. So even though we are doing biological medicine by the biological imbalance and psychological imbalance, it is in psychologist and counselor's role. So we learned a lot, and thanks for the very wonderful eye-opening session, ma'am. Thank you very much.
Thank you very much, Dr. Salim. Thanks a lot for that very crisp summary of my entire session, I think. Thanks a lot.
Yes.
Thank you. Thank you, Salim, sir. And now on behalf of all of us, I request our dear Dr. Suresh Kumar, sir, to talk a few words of thanks and conclude the session for today.
Thank you, Dr. Chandra, and thank you, Dr. Selvi, ma'am. It was an amazing session. And one word I can say from Srinivasan, sir. There are many stalwarts here who were as a participant, and they given the feedback here. He said that pragmatic, simple, clear to the person who has participated. That is the word he said. It's an amazing.
Thank you
and
so
few
much.
more words also used. I forgot the word.
Don't worry. Don't worry.
No, okay. And that is our the milestone session we used to find out a right person for the session. I think the 400 session we had a right person for the 400 session. We are going to have another 17 more sessions. After that, we're going to conclude the webinar and no more webinar after April 14.
Okay, that's sad.
Yes. And one more thing, it is about the number of participants who has attended today. And recently we had a session more than 30 to 40 days. We found the numbers nearly 20 plus. But we had 70 plus. It shows that threefold of participants who came today. So which shows that they are having huge respect and they know about your quality of content. So that is another thing I found.
Suresh, sir, I think I would like to correct it. I think the large response, I should never take credit for myself or the brand, but it was more for the academic interest in CBT as a therapy modality, which a lot of people are curious about. So definitely that's something that people are interested about. Yeah.
No, we had the same kind of topic CPT earlier, but for the number. Yeah.
Yeah, okay, fine. Okay.
So that's why I said the numbers it is because of the person who is presenting, and the 400 milestone also gives some
definitely
interest to the participants.
Yes.
And I take this opportunity to record my sincere thanks to you and gratitude to you for on behalf of the Department of Psychology, American College, and the other organizations like Madras School of Social Work, Chennai, MHLM Institute, Madurai, and Psycho-Oncological Association, Turkey. And in this 400 webinar session, I would like to thank few more persons also, our Secretary, Dr. Dominic Cristobal, sir. And when I was approached him, can I take up this? He said, yes, you can proceed. So I record my sincere thanks to him for the opportunity, and also record my sincere thanks to Dr. CR, sir, for his blessings, and the 40 members, Dr. Chandra. And recent days, support, I cannot be able to make it this program is more successful one. Thank you, Dr. Chandra and Dr. Subhasri from MSSW, Dr. Veena, and Dr. Salim, sir. And I specially mention to you because you made this program and circulating that program detail to all the group members. It is not an easy task, and you made every day you spend quality time for that. Thank you so much, sir. And I also thank the other 40 members, Dr. Ms. Ananya Lakshmi and Akshay Lakshmi and Ms. Bharati and all other members who directly or indirectly helped us to make this webinar series happening and successful one, and all the expert speakers and without any expectations, any commitment, and they agreed our invitations. And thank you all the expert and speaker members and all the supporting participants, Sitma sir and Gunapati Armam sir from Malaysia, Dr. Srinivasan sir, psychiatrist from Coimbatore, many people who were regular participants of our program. And thank you all, and also my students. Whenever I need space for them, and they also come forward, they help me. And all the family members and the family members for the support. I thank you all, and at last, I thank God for giving this wonderful opportunity to create awareness about mental health component. Thank you, Ma'am Selvi, ma'am, and it is an amazing session for our 400 session.
Thank you very much, sir. Thanks a lot for this opportunity, Suresh, sir. Thank you.
Yes. We will have a CBT workshop.
All of us. Sir,
We are
on behalf of
actually,
all of us, thank you.
if I may just add, actually, every year, Chelamuthu Trust, along with Ahana Hospital, we are actually planning to conduct a national level CBT workshop. So, yeah, so.
Ma'am, it should be international.
We'll start with national and then go to international. So I'm happy with being, starting national. So both Chelamuthu Trust and Ahana Hospital together, we are planning to hold national level workshops on CBT. So as and when we, start planning for that in this coming year, we start with a basic workshop as well as an advanced level and specifically for certain disorders. So when we do that, we'll be very happy to share with this enthusiastic group the notification, and most welcome to attend it as well.
And we are having the participant phase of more than 8,000 members, and we can circulate in Telegram as well as in WhatsApp.
Absolutely.
Definitely
That would be great help, sir. Yes, yes.
Yes. Dr. Chandra, final word from you.
Having spoken about everything, we can't miss to thank you, sir, because without you, this would have not happened, because this entire webinar series is your brainchild. We all know that. and we are greatly humbled to thank you so much for making this happen. You can't imagine what changes you have brought in everyone's life here. That was a great thing, sir. So stay blessed and be the same. We wish you all that. And dear participants, I'm also thanking all of you for traveling with us so far. And without you, it is incomplete. So thank you for your continuous support and cooperation. And that's all about. And special thanks to Selvi ma'am. I can keep her thanking because she has done a wonderful job today, a session of its kind, I would say. So thank you, ma'am, for being here. And thank you, one and all. See you all
Chandra
tomorrow.
ma'am,
Stay
I must say you're a very, very engaging co-host, or rather, we would call them as MC of the occasion. So you're a very, very engaging person. So glad Suresh sir has somebody in his team. He's got the talent to find the right person. So thank you very much for this. Thanks a lot.
Thank you so much, Selvi ma'am, because you see, this is what I told, what change this has brought in someone's life, and it is this seminar has taken this out of me. Thank you again, and you are so humble, I should say. Take it, ma'am. So
Thank you,
one and
Chandra.
all. Stay tuned for tomorrow's session, the same link, same time. Until then, bye-bye and good night.
Thank you.
Bye. Bye. Yeah, thank you.